Thanks very much, Conrad Cham. I'm sorry I'm not as well. But he's probably not sorry enough for me. So I've got a very different kind of presentation, I'm afraid, and I may have misinterpreted what I'm supposed to talk about. But I'm going to do it anyway. So I estimated that most of the audience here would not be very literate about health in South Africa. So I'm going to provide a bit of a background first, and then talk about some of the problems and challenges that we face. I'm going to talk about, very briefly, our comparative performance in health, what are the causes of this dire situation, and then I'm going to focus on some new policies which have generally been welcomed by the progressive movement, but I want to indicate some possible problems and then some priority actions to address some of the challenges. So, where is South Africa? This graph plots health as life expectancy on the vertical axis against wealth in GDP per capita with all its deficiencies. But you can see that in general there's a direct relationship. The size of the circle is the size of the country in terms of its population. So you can see that on the bottom right is South Africa, which performs exceptionally poorly in relation to its GDP per capita. Very, very poorly. If you look up the straight line, you will see Cuba has a life expectancy of about 30 years more than South Africa with the same GDP per capita. So our health performance is extremely poor. What are the causes? Well, we have a very, very high burden of disease. We have 4 colliding epidemics. Everyone knows about HIV and TB, but we have persisting problems with rising children, still a high maternal mortality rate. We have an epidemic of injuries and violence, and an accelerating epidemic of chronic diseases, including affecting working class people. For example, we are now, according to one survey, the 3rd fattest country in the world. So, what's the background to this? So, I haven't time to go into this in any depth, but say just looking at children, if you look at the poorest versus the richest, you can see that under 5 mortality is 4 times as high in the poorest group inside the circle, and similarly huge disparities when compared with educational, rural, urban, different provinces, and of course racial differences. So we have many, many inequalities in this country. Probably the most important fundamental determinant is poverty. So again, looking at children, in 2010, 6 out of every 10 children lived in households with an income of less than 600 rand. So GDP per capita means very little, because clearly the capitas have very different amounts. And I think we all know that income inequality has increased, so that now you can see the top 10% command almost 60% of the share of income in South Africa. So what are the key challenges to improving access to quality health care? So the Lancet Journal, which is a prestigious medical journal, did a series on South Africa a few years ago. And they suggested that these were the key actions that we need to strengthen the health sector. A dedicated, adequate and skilled health workforce, sustainable, equitable access to health services, competence and accountability from managers and leaders. Now I just want to point out, they're talking about health services. I've already made the point that social determinants, i.e. things outside the health, are equally, if not more important. However, the medical journal focuses on these things. So, what about the health sector? Well, we know we have a highly unequal health sector. 8 million people have approximately 11,000 rand spent on them. Those are the people who use only the private sector. Those who use the public sector, 35 million, have less than 2,000 rand spent on them. And there's a group in the middle that use both. So very unequal funding, and South Africa's percentage of total health expenditure, which is private insurance, is the highest in the world, higher than the US, for example. And then we have huge problems with the health workforce, so that although South Africa has almost 4 times as many doctors per 10,000 population as the African region on the extreme left, there is extreme maldistribution. 1 doctor per about 600 patients using the private sector, and 1 to over 4,200 using the public sector. And so this translates into very poor health performance. Again, looking at child health, because that's my area of particular interest and qualification, you can see that for very basic interventions, for example, vitamin A supplements, only about 1/3 of young children receive these. Less than 40% of pregnant women receive antenatal care in the first 20 weeks of pregnancy, and so on. And when we look at our immunization, very basic vaccines, South Africa on the left, the triangles of South Africa performs about the same as the Africa region with poor coverage. Rwanda, a much, much poorer country, performs much better than the Africa region. So, we have 2 major new health policies which have been welcomed by, indeed, driven by union demand, trade union demand. And people will have read in the press about the NHI, National Health Insurance. I must stress, this is not a national health system. This is a national health insurance scheme to fund a health system. And this is being implemented by, at the moment, a policy called re-engineering primary health care. I'm going to say a few words about each of these because you probably don't know much. Apologies to those who do. So first of all, NHI. So this is a mechanism to address particularly financial inequality and catastrophic out-of-pocket expenditure. At the moment, about 17% of people experience difficulty in accessing healthcare, and about 13% of healthcare spending is out of pocket, which impoverishes people. They spend out of pocket because the public health services are inaccessible, overcrowded, or inadequate. So the NHI idea is to increase the funding of health services through increased allocations from general tax, a mandatory contribution by employers and employees, and, this has got the private sector very excited, removal of tax subsidies to those who use private medical schemes. These funds will be pooled and services will be purchased from accredited providers, both public and private. The medical schemes will remain, but probably will decline in membership. At least this is what we know. This is all we've been told. Everyone's been waiting for almost 2 years now for the white paper to emerge. It has not emerged. We presume that's because of conflicts between especially the private sector and government. So re-engineering primary health care is a way for the health department to try and strengthen the public sector in advance of this NHI, which is set to take about 15 years before it's in full operation. So there are 3 streams in this re-engineering. I won't go into all of them. I'm just going to focus on the first one. I'm not going to talk about school health services or specialist teams. I'm going to talk about the core of this, which is primary healthcare outreach teams based at ward or sub-district level. This is a diagram, very difficult to understand. I think I'll skip it, except to point out that there's a role for all spheres of government, and you can see that on the right, local government, which is represented here, has a role in environmental health. I think it's just a coincidence that local government is in a coffin shape. So the primary healthcare outreach teams, which are the core, will have nurse, health promoter, environmental health practitioner. Where they'll find them, I don't know, we don't have enough of them, and very importantly, community health workers. These people will go out, as I said, and each deal with 270 families, providing very basic health care. So, Jonathan Grossman talked about community caregivers, community health workers today, and I'll go through this very quickly because some of you were in that session. So we now know that community health workers, that is people with much less training than a professional worker, usually selected by their communities, can do a lot of things. They can do promotive, preventive, curative, and even rehabilitative work, and have, in some instances, play a catalytic role in their communities, in the community development kind of role. So, in child health, we know that children in South Africa, and of course elsewhere, are dying because they're not getting very simple interventions like vaccination or rehydration. And coverage is very poor, as I showed earlier. I'm going to skip through this fast because I'm running out of time, and I have a chairman here who's going to get me in trouble. So we now know, and in fact in many countries in Africa, almost 30, community health workers are even treating children with pneumonia. Why is this important? Because in this country, pneumonia is the second common cause of death. Children die very quickly of pneumonia, and they die on their way to healthcare facilities. So why shouldn't lay health workers administer antibiotics? Well, the South African Nursing Council says it's too dangerous to allow untrained people to administer antibiotics. Well, I ask, what's more dangerous than death? I don't know anything. So there's now quite a lot of evidence that CHWs can do this. And there's now robust research evidence that community health worker-led groups, just facilitating women's groups, can have an impact on newborn mortality and maternal mortality by helping people, essentially, I hate the word, but empowering people to be able to take coherent action when they know there's a problem happening. And community health workers can play a role in catalyzing social change. Although the current discourse about community health workers talks about them as healthcare deliverers and not as social mobilizers. So that aspect, an important aspect of their work, as with many other things in neoliberal discourse, has been completely discarded. But their success depends on a whole number of factors, which I don't have time to go into, but they do need important support, supervision, and of course, community trust. So, in South Africa, it's been proposed that we have one community health worker for 270 households. That's about 2,000 people. In Brazil, they have one community health worker for 500. In Thailand, one village health volunteer to 93. And in Rwanda, they have 60,000 community health workers, which is proposed for South Africa, but they have a fifth of our population. So clearly, in my view, we're not planning nearly enough of these, and we're not allowing them to do anything. This is an extract from their training manual where they inform mothers of deworming at least twice a year and to ensure the child gets vitamin A. So they don't even distribute deworming medicine, which you can buy over the counter. So their scope of practice has been completely restricted by professional eugenicists. So I'm only going to show one or two of these, and then I'm going to finish. Just wanted to check. Sorry, the comrade cut me off earlier. So in a number of much poorer countries in South Africa, there's been great success. And I just want to show a few slides from Rwanda, which doubled its health personnel in a 3-year period, most of them being lower level health workers like community health workers. They're now at 60,000, and you can see trends in antenatal care increased dramatically, trends in vaccination coverage, early child mortality. They've now got about the same under 5 mortality in South Africa, and maternal mortality has declined very dramatically. So this looks at under 5 mortality, South Africa versus Rwanda. So our community health worker program won't result, in my view, in desired reductions in child mortality or other problems without increasing their numbers dramatically and improving the ratio of community health workers to households. So I want to end now by saying, where are our policies and how likely are they to succeed? Well, there's been an estimation of this re-engineering of primary health care in pilot districts. There are 11 pilot districts in the country. And I won't go into all the domains that have been assessed, but basically red means, in the evaluation that was done, minimally or not achieved, green, nearly or completely achieved. So you can see for the ward-based outreach teams, the middle one, most are still red. School health teams, most are still red. Well, personnel exist in South Africa, but they're not moving to the rural areas. So the NHI could be a mechanism to redistribute healthcare resources, but there are a whole lot of things that are pretty murky now and need to be defined. An acceptable package of services, accountability in administration of the NHI fund could be a site for looting, as the Social Security Fund was. You know, in South Africa now we don't say luta continua anymore, we say the looting continues. And then this fund, which would buy services from private and public, could aggravate inequities because most of the private sector sits in the urban areas. So if all the private providers get accredited, it's likely to further disadvantage public sector. I'm almost finished. And we need to reconsider the ratio of community health workers to households. And in fact, in the much pilloried National Development Plan, which I would suggest is not all bad, there is this paragraph in italics: recruit, train, and deploy between 700,000 and 1.3 million community health workers. We on the left should be pushing for this. This is policy. The Department of Health is saying 60,000. The NDP says 1.3 million. Jonathan, this could be a way of getting community care workers employed and generating a lot of rural development. We need to rapidly increase investment in training and reorientate training. We need to reorientate health professionals to be able to address local social determinants and the specialists as well in the district specialist teams. And lastly, we do have statutory community representative structures such as health committees. They're in our Health Act. but they don't work. And they're not funded. Community members who belong to them have to pay their own transport to go to meetings. This should not be allowed. People's Health Movement is campaigning for that to stop. And we need to reduce the power of the conservative professional bodies like the Medical and Nursing Council, which are really a brake on progress. And in order to do this, we have to strengthen civil society in a partnership with unions. And I have to say that in interacting with Nahawa, we are trying to, People's Health Movement is working with Nahawa to try and explain some of these new health policies to them. It is mind-boggling to us, in the leading health service union in this country, that the shop stewards know nothing about the NHI. So if they know nothing about the NHI, how can we possibly have a movement which calls for a people's NHI? I'm going to end with a slide of this. If you're interested, you could look at what the People's Health Movement does. Thank you.